We will start with portal hypertension. First, what is cirrhosis? Cirrhosis is the end result of healing response initiated by chronic liver injury. And cirrhosis is characterized by development of fibrous septa surrounding the regenerating hepatocellular nodules. Surrounding the regenerating hepatocellular nodules. So that is called cirrhosis. So because of cirrhosis, there is a development of portal hypertension. And this cirrhosis can be classified as compensated or decompensated based on this absence or presence of clinically evident decompensating events. Decompensating events are like variceal hemorrhage, encephalopathy, and ascites. This classification provides the important prognostic information. That is, the compensated cirrhosis have median survival of 12 years, whereas decompensated cirrhosis have median survival of 1.8 years. Definition. So, portal hypertension is defined by portal pressure gradient. What is portal pressure gradient? Is the difference between the portal vein and hepatic vein. It is greater than 5 mg, 5 mm Hg is called as portal hypertension. So normal values. So normal portal hypertension is 5 to 8 mm Hg. When it is more than 8, like between 8 to 10 mm Hg, that is called portal hypertension. When it will become more than 12, then there is a formation of after 8 itself, there will be a formation of variceal. Then after 12, there will be a bleeding. Then if it is more than 20, then it will be uncontrolled bleeding. So here the best method to estimate the gradient is by transfemoral hepatic vein catheterization with the balloon tip catheter. However, the pressure higher pressure 8 to 10 mm Hg are typically required to begin stimulating the development of portal systemic collateralization. And then they have given the normal portosystemic collaterals like lower end of esophagus, umbilical vein, then hemorrhoids and all. Then come to the pathophysiology. In this picture also they have given the portosystemic anastomosis. Then pathophysiology. In pathophysiology, it is divided into prehepatic, intrahepatic, and posthepatic. Here, several factors may contribute to this. These factors are like increased passive resistance secondary to fibrosis and regenerative nodules. Then increased hepatic vascular resistance caused by active vasoconstriction by norepinephrine, endothelin, and other humoral vasoconstrictor. And then increased portal venous inflow secondary to hyperdynamic systemic circulation or splanchnic hyperemia. The last one, the splanchnic hyperemia, is a major contributor to the maintenance of portal hypertension as portal systemic collaterals develop. Unfortunately, the exact cause remains unknown, but still the splanchnic hormones then decrease sensitivity and splanchnic vasculature to catecholamines and increased production of nitrous oxide and protocyclin are involved in portal hypertension. Then come to the prehepatic causes. Most common prehepatic causes, portal vein thrombosis, extrahepatic EHPVO. It is accounts for 50% of the portal hypertension in children. Then it is hepatopetal. That is when the portal vein is thrombosed in absence of liver disease. That is hepatopetal to the liver. Portal collateral vessels develop to restore the portal perfusion. This combination is termed cavernomatous transformation of portal vein. Then isolated splenic vein thrombosis means that is left-sided portal hypertension, also called as sinistral portal hypertension, is usually secondary to pancreatic inflammation. Because due to chronic pancreatitis, there will be a splenic vein thrombosis. Because of that, there will be a portal hypertension. So it is that this results in splenic venous hypertension with superior mesenteric and portal venous pressure remaining normal. Only left side system will be affected. Here it is reversed by splenectomy alone. Next page. Then the site of increased resistance in intrahepatic portal hypertension may be at the pre-sinusoidal level or sinusoidal level and post-sinusoidal level. In pre-sinusoidal level, intrahepatic pre-sinusoidal by schistosomiasis infection. In addition, many causes of non-alcoholic cirrhosis result in pre-sinusoidal portal hypertension. In contrast, in alcoholic cirrhosis, there will be sinusoidal will be affected. Because why? Because there is to be secondary deposition of collagen in the space of disc. Also, in post-sinusoidal, secondary to regenerating nodules distorting the small hepatic veins. In post-hepatic and post-sinusoidal causes, the important one is Buchiari syndrome. Here, hepatic vein thrombosis or IVC thrombosis, IVC web can occur. Here also constrictive pericarditis and heart failure also can cause post-hepatic portal hypertension. Then assessment of chronic liver disease and portal hypertension. In this assessment, first we have to assess any underlying liver disease are there or not, or estimation of functional hepatic reserve, or definition of portal venous anatomy and hemodynamic evaluation, then identification of site of upper gastrointestinal hemorrhage. Here, like example, estimation of functional hepatic reserve is useful in determining the risk associated with therapeutic intervention, whether we can go for definitive treatment or we can go for palliative treatment, like definitive like hepatic transplantation or palliative like endoscopic and other shunt procedures. Then come to the most common complication, variceal bleeding. Here, 1/3 of all deaths patient with cirrhosis due to variceal bleeding. Approximately 50% of these deaths are caused by uncontrolled bleeding. Okay, then come to the treatment. Treatment as usual, as a hemorrhagic shock, we will start the resuscitation by ABCDE. Then we will
additional point. Once bleeding is controlled, the greatest risk of rebleed from varices is within first few weeks after the onset of hemorrhage. Risk declines rapidly between that point and 6 weeks. The last 3 lines.
Yes. Okay. Okay, come to the treatment. In treatment, usually according to the studies, when the hemoglobin level is less than 7 milligram per deciliter, we can go for blood transfusion. Above that, there is the mortality rate is same. But when it is less than 7 milligram, there is a response is there. Then for acutely bleeding patient with portal hypertension, non-operative treatments are generally used as a first-line approach, as these patients are have high operative risk because of decompensated hepatic function. So endoscopic treatment like sclerosis ligation can be given. Then pharmacotherapy, balloon tamponade, tips can be given. Now we will see it separately. First, endoscopy. About 80 to 90% of acute variceal bleeding episodes successfully controlled by endoscopic measures. Most commonly used methods are 2. One is sclerotherapy, another one is band ligation. Nowadays, band ligation is the modality of choice for initial control of variceal bleeding. Then endoscopic sclerotherapy may be used if technology of band ligation is not available. Then early endoscopy is preferably within 12 hours of admission, with an attempt to control of bleeding is recommended. Then patients should be started with vasoactive drugs. Actually, what they are recommending is, along with endoscopy, we should start pharmacotherapy to get a adequate response. Then come to the pharmacotherapy. Here, what pharmacotherapy drugs are doing is reducing variceal blood flow, which in turn reduces the variceal pressure. So actually, as pharmacotherapy, we can give antibiotic prophylaxis to decrease the infection rate. The infection rate, it decreases by 50%. Then somatostatin and its longer-acting analog octreotide can be given. In nowadays, because of combination of octreotide and endoscopic therapy, it is more effective than octreotide alone in controlling bleeding, as it is preferred treatment for most patients. In severe cases of hemorrhage, vasopressin can be given. But when vasopressin can be given, there will be decrease in splanchnic blood flow. But it can cause hypertension. So further, along with nitroglycerin should be simultaneously infused. Then variceal tamponade. In variceal tamponade, most commonly, we use Sengstaken Blackmore tube. The picture is given here. Here, the important point is there is an accessory NG tube is there for suction in the esophagus. Then there are 2 balloons. One is gastric balloon, one is esophageal balloon. In gastric balloon, we will infuse with 300 ml of air. In gastric balloon, it is 40 mmHg. So this is ml and this is mmHg. First, we will infuse the gastric balloon Then we will see whether the bleeding has been stopped or not. If it is not stopped, then we will inflate the esophageal balloon also. Then maximum hours we can keep for 12 hours. This sense-taking tube we can use it for 12 hours, but this tube can be only used in venous bleeding, like variceal bleeding most commonly used. It cannot be used in like arterial bleeding, like Mallory Wister, dilaphrosylation. We can't use this. The interventional approaches. In interventional approaches, most commonly used.
These points are not in the book.
These points are not in the book.
Okay, Venga from notes.
This is from notes, Rajamendra notes and Bailey.
Okay. Continue.
Okay, then interventional notes. Interventional approaches most commonly used as TIPS. That is the transjugular intrahepatic portosystemic shunt. Most commonly used material is PTFE. Then operative approaches. In operative approaches, most commonly here what they are mentioning is esophageal transaction with stapling devices used here.
One more extra point. Actually, the SS preparation is different from PG preparation. Okay, so we have to know a little bit more. So they'll ask true or false statements. So tips and the last 4 points are very important. Use of tips in patients with multi-organ failure or in patients with decompensated liver disease is associated with high 30-day mortality. In such patients, early use of tips rather than after failure of other therapies may be associated. So this is an important concept. So you have to use tips early rather than failure. So all these things, if you solve multiple question banks, they'll be asking questions like this. So that's what. So we have to read line by line actually. So that's the difference between PG and mid super specialty.
Okay, sir. So actually, here what they are telling us, we can use the tips like emergency when endoscopy and it failures, then we can go for an early intervention. We can go for tips rather than non-selective shunt.
Yeah.
Hello.
Okay,
sir.
Continue. Yogesh yaro guest vandirukanga nenikiren.
Okay. A commonly performed shunt operation in the emergency setting is portocaval shunt. That is rapidly and effectively decompresses the portal venous circulation. In patients who are not actively bleeding at the time of surgery and in those in whom bleeding is temporarily controlled by pharmacotherapy or balloon tamponade, a more complex operation such as a distal sphenorenal shunt can be done. The operative mortality rates exceed 25% or 75% in most reported series in emergency surgery. In emergency surgery, the mortality is 25%. Then prevention of recurrent variceal bleeding. Here they have given the same, like what are the modalities available, like pharmacotherapy, then chronic endoscopic treatment, then tips, then shunt operations. Example, non-selective, selective, and partial. Then definitive treatment, we can go for liver transplantation.
Yogesh mute பண்ணிரு. நீ admin நீ தானே?
ஆமா சார்.
Yogesh mute பண்ணிரு. Okay, அது எப்படி it's recorded ல he'll yeah, அது automatic unmute ஆயிருதா?
Yes sir.
Okay. So okay, continue.
So here, then prevention. In prevention, first point is pharmacotherapy. In pharmacotherapy, what pharmacological agent they are telling us first is beta blockers. So it has shown the effective treatment significantly decreases the likelihood of recurrent hemorrhage and mortality. In combination with beta blocker,
Sathya 1 minute. நான் யோகேஷ் கால் பண்ணி சொல்லிடுறேன். Okay, அவன் phone எடுக்கல, நீ continue பண்ணு.
Then pharmacotherapy, beta-adrenergic beta blockers can be given along with long-acting nitrates also we can use. That is isosorbate 5 mononitrate can be used. Or combination therapy also most effective. Then endoscopic therapy. In endoscopic therapy, the combination of variceal ligation and pharmacotherapy with non-selective beta blockade is more effective than variceal ligation alone. Then according to some studies in this trial, the combination of beta blocker and endoscopic treatment reduced rebleeding rates at 6, 12 and 24 months. Furthermore, the mortality at 6, 24 months was significantly lower for combined treatment group. Then next point, recurrent bleeding still occurred in approximately 50% of endoscopic therapy patients. And the initial year, in the first year of first time variceal bleed, there is a high chance of rebleeding is there. Then every year there is a 15% decrease in variceal bleed chance. Then although a single episode of recurrent hemorrhage does not signify the failure of therapy, an uncontrolled hemorrhage, multiple major episodes of rebleeding, and hemorrhage from gastric varices and hypertensive gastropathy all require that endoscopic therapy to be abandoned or another treatment modality.
Hello, not audible. Hello, Sathya. Hello, Sathya.